Καλή σας μέρα. Καλημέρα σε όλη την κοινότητα.
Καλημέρα και καλή Κυριακή σε όλους.
Έχουμε καλεσμένο διατλαντικό. Έχουμε περάσει έναν ολόκληρο ωκεανό για να φέρουμε στην τοπική κοινότητα ιδέες, πράγματα και νέα τα οποία έρχονται από τον Καναδά. Ο Καναδάς έχει το ιδιαίτερο χαρακτηριστικό ότι δεν βρίσκεται ακριβώς εκεί που βρίσκονται οι ΗΠΑ ό,τι αφορά όλο το ρυθμιστικό καθεστώς των φαρμακείων. Και τον τελευταίο καιρό, όλοι οι φαρμακοποιοί στον πλανήτη έχουμε λάβει νέα για διάφορες πρωτοβουλίες που έχουν αναπτυχθεί στα κοινοτικά φαρμακεία, μέσα στα οποία περιλαμβάνονται, για παράδειγμα, οι μαζικοί εμβολιασμοί για διάφορες καταστάσεις, για τα οποία θα ακούσουμε πολύ περισσότερο από το σημερινό μας καλεσμένο. Σας προτείνω λοιπόν να καθίσετε αναπαυτικά και να απολαύσετε αυτή την πολύ ωραία παραγωγική συζήτηση. Ο καλεσμένος μας είναι Έλληνας, αλλά αισθάνεται πιο βολικά να κάνει τεχνική συζήτηση στα αγγλικά, οπότε από εδώ και στο εξής θα αλλάξουμε τη γλώσσα. Ηλία, ο λόγος είναι σε σένα.
So, good morning. It's actually very early in the morning there in Canada. Is that correct?
Yes, 7 a.m. No, thanks for having me, guys.
Okay, this is Dr. John Papastergiou. He's a Greek-Canadian. He is an owner of 4 independent pharmacies, community pharmacies in Canada. He is also an assistant professor in the University of Toronto and Waterloo, I think, if I say that correct.
Yep.
And he's a spokesperson for the Pharmaceutical Association in Canada. He's very active in speaking, in giving lectures to some events of the Pharmaceutical Association there in the university. And it's a great honor to have him here and let him share with us his experiences and what they are doing there in Canada, so we can take some kind of cue and perhaps copy something or make it in fit somehow our standards. Welcome. Καλώς ήρθες.
Thanks for having me. It's good to be here. I've actually done a conference in Greece one time in northern Macedonia. I remember about an hour away from Florida. It was the Northern Macedonian Greek Pharmacists Association invited me to speak at their conference, so I was able to go down. It was a good time. I met a lot of Greek pharmacists.
Where is your original? Where do you come from in Greece? What is your heritage here in Greece?
Yeah, both my parents are from Florida now, which is a town near northern Greece. So I come to Greece every few years, so I'm pretty familiar with the culture and even kind of how pharmacy operates a little bit in Greece as well.
But we don't know how pharmacies operate in Canada. So we'll get there.
Very different.
But before that, we have to discuss the issue, you being an owner and a community pharmacist and somehow managing to be an associate professor in the university there. As Yamadis would say, what kind of wizard is that?
Yeah, it was a weird career path. I actually started my career in hospital pharmacy. So I graduated from the University of Toronto, and then I worked for a couple of years in hospital pharmacy, and my independent pharmacies are actually part of a pharmacy chain. So they're independently owned, but we're the biggest drugstore chain in Canada. And back then, this was 2005. I was working relief pharmacy as well, kind of in community pharmacy. And the opportunity came about to buy my first franchise here. And it's actually, interestingly, in Greektown, in Toronto. There's a well-known part of Toronto called the Danforth, which is primarily Greek heritage, Greek restaurants. It's a very big Greek community. It's the biggest in Canada. And that's where my first pharmacy was. And all 4 of them are in that community still. So I do service a lot of the Greek community. I do speak Greek a little bit, not the greatest, but it's good enough to get me through with our Greek patients, and we still service a lot of them, like I said. So that's kind of how I ended up in community pharmacy. I opened my first pharmacy there, and then as the business grew, we continued to open them.
But how is it possible for someone being an independent pharmacy, community pharmacy, having a position in the university there as an associate professor? This sounds very strange to us, because when we think about professors here in Greece, there's no chance that some community pharmacists could ever be a professor, appointed professor in any university here in Greece. That sounds absurd to us.
Yeah, it's almost like I did things backwards. So what had happened is I took a lot of the learnings from hospital. So hospital pharmacy, I really My role there was I was a clinical pharmacist, but at the same time, I was doing quite a bit of research, different areas kind of on the floors. And when I got to community pharmacy, I noticed there was a demand for what we call now practice research, for kind of real world evidence to help support the evolution of pharmacy practice. So I remember, this is going back now 15 years, the first paper we ever published was a simple paper around A1C screening. So I took kind of some of these learnings from hospital. I said, why don't I apply them to community pharmacy? So I became interested in innovative clinical programs, things that would differentiate my practice from other community pharmacies. And at that time, I started to collect some data, and I had, some help from university students that were on rotations and whatnot. And I remember we submitted our first paper back then, and it got accepted almost immediately, not because it was a great paper, more because no one from community pharmacy was actually submitting any of this type of work. So there wasn't a lot of evidence to suggest, hey, this is what pharmacists in the community are doing. Obviously, we had pharmacy journals both in Canada, the United States, and Europe, but a lot of the work at that time being submitted to those journals was from academic pharmacists, researchers, hospital pharmacists. So very few community pharmacists would submit anything. So quickly that paper got accepted, and then I started submitting more work as we evolved our practice. Those papers started getting more interest. A few years back, I won something called Canadian Pharmacist of the Year. I was the first real community pharmacist to win that prize. So then it kind of got me speaking at conferences. We started dabbling into kind of more complicated work, things like pharmacogenomics, point-of-care testing. Our paper in pharmacogenomics won first prize at FIP a few years back in Argentina. So all this stuff started snowballing. Then you get grant money, so people started giving you money, pharma companies, other industry, to do more work, and then it grows. Then you have more people involved. The quality of the papers get better. We just published a randomized trial maybe a year and a half ago that was done entirely in community pharmacy, blinded. It was very difficult to do, actually, but we were able to do it. So it just kept growing and growing. And we kept becoming interested in areas that we thought there was opportunity. We spoke a little bit about immunization before we went live. A lot of the early work around the evidence that pharmacists could play a big role in immunization was done by us. And this was with flu data years ago, So the work now, we've got over 20 publications, thousands of citations. We continue to grow that body of work. And now I've had the fortune of collaborating with a lot of colleagues from Europe. There was an organization called IPACT, which was really a group of international pharmacists, academics, researchers, with the goal of, initially it started around providing better care around anticoagulation, but now it's really become an international group of pharmacist researchers that are trying to provide evidence to push the entire global community forward. So we've done a lot of work with that group as well. So I think it's great that you guys are doing a program like this and sharing, I think, best practices from across the world.
Yes, we're trying to do that.
Yeah, I find this concept of real world data and evidence from everyday pharmacy practice very compelling. And this is something we've been trying to do, and I'm pretty sure Elias, more than others, has been trying to do for years. So I'm very keen to listen if you have any real world advice for us. Right? Where should we get started? From where?
Start small. I think,
perhaps.
Yeah, I think it's see what's done already. A lot. It's like if you dive into the evidence out of like Australia, Canada, the UK, the US, a lot of work has already been done. So there's already that kind of that groundwork that's already been set for you. Now it's trying to determine, okay, what's important in Greece, what's important to the regulators, where can we get some buy-in from stakeholders? That's very important. And where will the reimbursement come? Because I'll tell you something, you're not going to be able to do anything for free, not long term, right? So if reimbursement doesn't follow, I find you can have the greatest ideas, but they won't be sustainable, or you won't get buy-in from the broader community. So we started with things like, actually, I started with things that interested me. So a lot of my early work was, and it still is, in point-of-care testing. I think community pharmacists, they really are unique in the sense that they're convenient, they're accessible, and we have the ability to see patients much more frequently than family physicians. We have a universal healthcare system here in Canada, which is great. The challenge is access. Canadians wait, quite a bit of time, over a week, to see their family doctor, 5 or 6 hours in the emergency room, sometimes months to see a specialist, right? So where they come more often is the community pharmacy. The pandemic shot this forward, I think even maybe 20 years, because when the pandemic hit, family doctors, they went to virtual care. They shut down in Canada. I don't know what they were doing in Greece, but
here in Greece as well.
Yeah. So where was everyone coming? They were coming to their community pharmacists, because that's where they could actually speak to someone live in person. We were trying to do our best with PPE and following all the standards. We had a long lockdown here in Canada as well, one of the longest in the world, right? We're still just opening up, really, but the reality was this opened up a huge opportunity for point of care testing. The vast majority of rapid testing is done in community pharmacies. Collection for PCR, I have a molecular PCR in my pharmacy, so if you come in, I could do a real-time PCR, and you get your results in 15 minutes. I have something called the Health Tab. We're able to do 21 biomarkers in 15 minutes, and it goes right to the patient's phones. A1C, lipids, serum creatinine, liver function, all these things that you'd have to go to a lab to. Historically, we're able to.
What I want to ask is how people, doctors and other companies with microbiological labs have reacted to you.
That was my question as well.
Access to this kind of tests. And also I want to ask if the reimbursement comes from the health system or is out of pocket for patients?
Depends on the program. That's a great question. So 2 things. The other stakeholders are always going to push back. But if you worry about that, you're never going to get anywhere. We've been having this discussion for years and years. Every time we go down a path of new scope, what are the physicians going to say, right? They're going to, they're going to push back. But the reality is, if the public demands a service, they're going to want to get it for you, irregardless of what the other people say. And for us, we've shown patients what pharmacy is capable of doing, and now they come to us demanding the service. So scope of practice, we didn't really talk about it. In Canada now, in pharmacy, varies depending where you are in the country. The most advanced province is a province called Alberta. It's kind of in the middle of Canada there. Pharmacists there have full prescribing authority. They can write prescriptions for whatever they want, right? So that's ideally where we want the whole country to go. And it varies depending where you are coast to coast. I'm in the province of Ontario. We're able to do a lot, initiate prescriptions for certain drugs. Minor ailment prescribing is coming. We can extend prescriptions if patients run out. So the scope it varies, but ultimately we're all pushing towards being able to get full prescribing authority.
Yes, but how do you get around this pushback from other stakeholders? How do you do that? Because usually here in Greece, when the state has to make to decide where to lean, usually bigger stakeholders tend to win, regardless whether this is a logical demand on our side. Let's say, for example, compounding pharmacy. Okay, we have the same way that we operate in compounding prices for the last 45 years, which is counterintuitive, is out of date, and doesn't make any sense because it has some kind of dosage forms that have been extinct for about 20 or 30 years, something like medicine, something like that. And we cannot pass through the legislators to change things that are in compliance with all the international practices and the common sense. let alone convince them to go against the will of a very powerful stakeholder like the doctor, stuff like that. How do you get around that? How do you lobby about this?
Yeah, so I would say it's multifactorial. So it starts first with a strong lobby from the pharmacists. So the pharmacists have to be united. If they're not united in kind of what they want to see with respect to profession, it's going to be tough. But you start with that. Kind of second fold, hopefully you get some support from the public. The public here in Canada is used to getting services now in pharmacy. It wasn't always like that, but I think they saw the value of the community pharmacists. And third, and I think most importantly, is you have to start with something that's an easy win. I always say the easiest is flu. If you start with flu vaccination and you get that scope and you do a good job with it, then you can move on very easily to other things. So flu is a low-hanging fruit. It's every year we have flu, it comes. We struggle to get the public vaccinated historically with public health clinics, or physicians really didn't have the time to do it. So it fell in the lap of pharmacists, and we do a good job. In Canada now, about over 3 million flu shots are given in community pharmacies, right? That's the vast majority, more than anywhere else. So it started with flu. And then you think of something like the pandemic. We've given, I think, 7 million COVID shots in community pharmacies. Me alone in my pharmacies, I've done 40,000 COVID vaccines between my 4 stores.
Would you do the honors asking about the COVID vaccinations?
Yeah, so and it's a reimbursed service too, right? So we get paid obviously for it from pharmacies. But it started when we started, they were skeptical, right? Like even for flu, it was a slow go. We started the first year, we only did 256,000 flu shots, I remember, because pharmacists didn't have the training. They had to get caught up with training, so they had to do the training and everything else. But the reality is it's simple. It's something that you could do easily. We're even talking about pharmacy technicians doing vaccinations now, because the burden is so, pharmacies are so busy now, not only prescriptions, but with all these other clinical services. Like, to give you a perspective, in a given day in my pharmacy, a busy kind of pharmacy, I might do 600 prescriptions, but during the peak of the pandemic, I'd maybe do 500 COVID shots, 200 PCR tests, and maybe another, 100 rapid tests. So I would have 4 pharmacists working. I had to employ 2 nurses just to keep the workflow going. We had lineups down. I give presentations where I show the slides and you see lineups down the street, right, to get these services done, but they were all done in a community pharmacy. The public hasn't forgotten that, I think, and it's helped now as we push for more scope and we come out of this. I think all this stuff around point of care and vaccination, it's going to be routine in pharmacies. But again, I'm getting off topic, but I think my point here is, if you start with something easy, and I remember being at a FIP meeting in Vienna, and there was Greek representatives there. And I remember this story because they asked the group, and there was people from different countries, they asked who's able to give vaccines in their pharmacy, right? And the representatives from Greece put up their hands and they said, hold on, we don't have you listed here as FIP as one of the countries that could do vaccination. And I remember the representative said, no, we're not, but we do it anyways, especially in the small towns. And I mean, so you're doing it anyways. Now you just have to get it formalized so it spreads quickly, right? And I think once you get that a win, you will see how quickly some of the other, practical kind of clinical opportunities come your way. And I think for us, scope moved very quickly in Canada. In the last 10 years, we've done more probably than in the last 50, right? So it does come quickly when it comes.
Have the local authorities confirmed the value of the community pharmacy services besides the public? I mean, have you seen statements or, let's say, other key signs from the authorities that they accept this contribution as vital?
Yeah, I think so. I think politically, the politicians have recognized it for sure, and that they're pushing stuff our way now because they're under a lot of pressure. I mean, governments are broke. The pandemic has caused huge amounts of spending, and they see a pharmacist as an opportunity to help pull some of this pressure off. I think even our other professions now. I mean, you start seeing papers from physicians. There was a paper a few years back in the Canadian Medical Journal where physicians looked at the value of pharmacist-directed immunization, and they showed, hey, yeah, in those jurisdictions where pharmacists vaccinate, coverage rates go up, right? So now it's not a paper published by pharmacists, but by, a physician. So that type of support helps as well. The reality is, I think there will be no option. If you look at something like diabetes, this is an example I give all the time. This is the next pandemic. I mean, I know the Canadian data, but we're going to be looking at, something like 3 million new cases a year here of diabetes, right? Who's going to manage that? Like, you can't expect that to fall on the primary family docs. They don't have the time to do it. They're going to look elsewhere. And I think, pharmacists, if you were ideally suited to do the screening, the management, obviously the dose alterations, escalations, all those things that are needed. I mean, the frontline physicians aren't going to be able to handle that wave of patients with diabetes, or they're not going to be able to do it well. And there's definitely not enough specialists. So that's just an example of, one chronic disease, hypertension, dyslipidemia. These are things that you can manage easily in pharmacies, and the technologies available now that allows us to do it with some good biomarkers, lab data, and everything else.
Do you get a pushback from pharmacists for all this changing role that they think sometimes that the things that they do every day have nothing to do with what they studied or what they started working for? They see this shift in their role, in everyday role, and for some reason they are afraid, they don't recognize their responsibilities, they don't feel that they are fit to practice. I don't know why. Do you get pushback there in Canada?
Absolutely. We used to get more. We used to get more than we do now. I think two things happened. I think, there used to be, like, pharmacy obviously was rooted in dispensing. That's how it had been here in Canada. Your primary role, even when I graduated back in 2002, was you dispensed the medication, you answered some questions, and you sent the patient on their way. A couple of things happened. The pharmacy undergraduate, or the pharmacy schools, changed their degrees. They went from undergraduate degrees to PharmDs, doctorate degrees. So that was a big thing. They changed the mindset of the pharmacy students coming out, right? That was one part. The second part of the whole thing was drug reform hit in Canada. So generic drug deflation brought down the profitability and the margin associated with filling those prescriptions. And it did it very, very quickly. So pharmacy went from being very, very lucrative as a profession where you just dispense drugs and you didn't really need to do anything else because you were making so much money doing it, that the margins got so slim. And I mean, I see it from the business side as well, right? That we were looking for other things to do to compensate for that. And what, some pharmacists did was they invested a little bit to try to drive clinical service revenue. And I think they're the ones now that are doing the best. Those pharmacies that kind of did the opposite. They're like, oh, I'm going to cut a little bit of labor, try to manage, just filling these prescriptions and stay tied to the old model. They're struggling. And I think they're unfortunately going to be dinosaurs here in North America, because that's not really what the public wants. I mean, in our company now, we're centralizing most of the dispensing anyways. It doesn't get done on site. The technology of the pandemic has helped patients recognize the value of apps. You want to refill your prescription, you go on our app, you refill it. It gets done at our central fill facility, and it comes to my pharmacy the next day, and you can pick it up, right? So we're not actually spending as much time now filling prescriptions. I would say about 200 prescriptions a day for me go automatically to the central fill facility. And it does two things for me. It frees up pharmacist time, but it also reduces my cost to fill dramatically. It's cheaper for me to send it there and have it done for me than for me to pay someone to do it in my pharmacy.
So it's more profitable, you're saying?
Absolutely more profitable. So to give you the cost to fill, and I can tell you in Canadian dollars, to fill a prescription in one of my pharmacies, about $4. That's what it costs me to do per script. If I send it to the central fill facility, you get it down to less than $2, right? A prescription. So it's dramatically, and when you're filling thousands of scripts a year, that has a material impact on your bottom line.
Mm-hmm.
But do you feel confident about the prescription being filled somewhere that you have no control over what happens, and you have to see if there's somehow a way to trace what went wrong in a remote place or something like that?
You got to remember, Ilya, it's all automated, right? Like the central fill facility is not people doing it; it's all robots. If there's going to be a mistake, the mistake happens at your pharmacy when your staff enter it, right? So we do the order entry. The robots don't really make mistakes. It's very rare. Like, I mean, it can happen, but I'm telling you, we've sent hundreds of thousands of scripts over the last few years, and I've rarely seen an error. We do send our compliance packs there as well. So compliance packs are like the blister packs that come like in weekly, like 7 to 8 fills for patients. There, occasionally you see an error because the robot it jumped a slot or something, but generally it's not a mistake with the drug. It's maybe in the wrong spot, right? But the error rate of central fill facilities is very, very low because it's entirely automated. The errors are made on the human side. If you make a mistake transcribing it or entering it into the system, once it gets sent to them, it's pretty much humans don't really touch it, right?
Okay, so
I'm assuming you will have fail-safe, let's say, procedures.
Well, it's something to see. Yeah, like, I mean, we don't know. We're getting into the regulatory aspect, but if you use a central fill facility here in Canada, we're regulated by our college. It's called the Ontario College of Pharmacists. The liability on the filling falls with the facility itself. It doesn't fall on you, right? So the filling liability lies with them. It's like you're using a third party to fill. All the other aspects of the liability fall on me. So if I enter it wrong, or I don't do a therapeutic check and maybe it's inappropriate and I send it there, you're still responsible for all of that as the pharmacist. The physical act of dispensing now has moved on to the central fill facility, right? So the liability falls on them. For a central fill to be worthwhile, you have to have volume. So it's not just me sending to central fill; it's our entire chain, right? So last I heard is they fill something like 50 or 60,000 scripts a day at that facility, right? So it's very, very high volume facility, but that's what continues to bring the cost to dispense down. And I'll tell you, the way federal and provincial governments are, they spent a lot of money I think in pharmacy over the last few years with the pandemic. I think we're not to finish seeing drug reform globally. I think we're going to continue to see generic drug deflation. Prices will continue to go down. Margins will continue to be slim. And if you look at the innovative drugs coming down the pipeline, most of them are biologics, right? You don't see many innovative like oral kind of pills that will maintain kind of those brand name margins. Well, I mean, I don't see many coming. I mean, there's a few, but not tons.
Let me ask you something. The vaccination program in Canada was entirely done by pharmacists and physicians. They didn't have a centralized way to do vaccination in facilities that were developed for that purpose, like here in Greece.
Oh yeah, no, we did have a mixture of those as well. So we had public health clinics, right, where you could go to the public health clinic or make appointments and go, because we have to vaccinate everyone over a pretty short period of time. And our 2-dose vaccination rate here in Canada is quite high. It's in the high 90s, like 97, 98%. Where we're falling behind is on the boosters. The 3rd dose uptake is still very low. It's only about 30%. And we have to do a better job with that. But yeah, no, you could, primarily it was in pharmacies and public health clinics. The physicians didn't play a big role. Most of them were working virtually at the time, so they weren't in their offices to give vaccines. And I think at the volume that we were doing, like, I don't think physicians' offices would have been able to manage it. Like, physician's office might do 60 vaccines in a day if it's very, very busy, right? We were doing at the peak 500 or 600 in one of my pharmacies. We're just set up to be able to do a lot more, right?
I would like to turn this conversation a little bit around right now. You stated before that you own 4 independent pharmacies that are part of a larger chain pharmacy. Is that correct? So
yeah.
I would like to know how, that sounds a little bit conflicting in my head. So how does that work? Can you give us an outline of how that works?
Yeah, so if you're to own a pharmacy in Canada, it has to be owned by a pharmacist, right? So we do have chains, banners, grocery stores that have pharmacies as well, but generally they're owned by pharmacy. So my chain is a chain called Shoppers Drug Mart. It's the biggest pharmacy chain in Canada. We have 1,400 locations across the country, across about 650, 700 owners, right? So most of the owners own anywhere between 1 and 4 locations. I actually chair our owners association, so I represent our owners, and it's a very unique model. It was started by someone called Murray Koffler, I think back in the 30s, 40s, somewhere there. And his idea was he wanted to empower community pharmacists to own their own pharmacies, but because they weren't necessarily businessmen, he wanted them to have the backing of a larger corporation to help them with things like HR and other aspects. That being said, my pharmacies are not like the pharmacies I see in Greece. They're generally much, much larger, right? So my pharmacy, my biggest one would be around 14 or 15,000 square feet with full beauty section, full grocery store, obviously OTC, seasonal, and then a pharmacy as well. So they're very, very big stores comparatively to something like CVS or a Walgreens in the United States, maybe a little bit bigger than like Boots in the UK, right? So although they are community drugstores, they're bigger, but they're not massive grocery stores either. So they kind of fall somewhere in between. We are responsible. You're not just responsible for the pharmacy, then the front store becomes a big part of the business as well, right? So you have to be, you learn very quickly about, produce and food and cosmetics and everything else. So your role goes beyond just the pharmacy. But it is, I didn't answer your second question. Is there sometimes a conflict? Absolutely, right? Because you're operating within the walls or the confines of a brand model as well. So you can't just do whatever you want either, right? Because the idea is to be a recognized, and we are one of Canada's most recognized brands. Each store has to be kind of the same as well, right? Across Canada. So you can't, although you have freedom to practice the way you want, and there's a ton of support to be innovative and clinical and whatnot, you do have to meet those basic kind of requirements of the corporation as well, so that you don't compromise the brand or you don't look much different, because that's what the Canadian public recognizes, right?
Do you, the company, the headquarters, have to make sure that all the pharmacists remain in touch with expert knowledge and new facts about the science? Do they do some kind of training, ongoing training, or is this up to the hand of the owner of each pharmacy independently?
So you are responsible as a pharmacist, irregardless of the owner, of a staff pharmacist, or pharmacy manager. You're responsible and required by our college. We're a self-regulated profession. So in Ontario would be the Ontario College of Pharmacists, to meet those kind of quality assurance requirements or standards or minimum standards of practice. So it's up to the pharmacist to maintain what we call a learning portfolio, meet certain educational requirements every year to stay up to date. And there is a process in place by the college that randomly checks, right? They do come to pharmacies and assess pharmacists to make sure they meet those requirements. That being said, our company is actually really good at providing education for our pharmacists, the ones that work there, not necessarily the owners, but actually all the pharmacists, because I employ probably 30 pharmacists, and they're able to go online, and we got accredited programming that they could listen to and watch, and that help them meet those educational certification type stuff that they've got to do each year.
What do you stand about the e-pharmacies and the e-commerce in pharmaceutical or parapharmaceutical products?
I don't know. It doesn't seem so. Everyone's worried about here in Canada. We have Amazon that's come into the Canadian market with PillPack. They're kind of online pharmacy. There's a few others. The reality is this is a debate that's been happening here much longer than Amazon, and it hasn't been very successful. I think I think the pharmacist owns the relationship with the Canadian public. And here in Canada, and I don't know if this is unique here, but the patients like to come in. It's part of their routine to visit their pharmacist, ask questions, pick up their medication. You know, we could very easily take our central fill facility and send the medication straight to the patient's house if we wanted to. We don't do that because they like to come in and talk to us. They like to spend time in the store. They like to spend in the store. And obviously we want them in our store. If we're going to compete,
like,
sorry.
Yeah, that sounds like a very similar experience to what we're experiencing here in Greece. It seems that patients and customers like to walk in a pharmacy and have this very humane interaction with their pharmacists, and that has built a lot of trust in the process of time.
And that's
also been very prominent in the pandemic era as well.
Of course,
where we were the only store, perhaps selling cosmeceuticals and other stuff. I've seen last Christmas where everything else was closed because of the lockdown. This was something that I've never seen before in my career, and I'm a 20 years pharmacist, community pharmacist. Everybody was buying their presents from the pharmacy, and they were very grateful that the only store in the community was the pharmacy. So that we have never sold more gifts and presents in our career, and perhaps we will never do that again as well, because everything is open, the market is open right now. But you've seen people coming and being grateful for the opportunity to have an open store and the opportunity to have a human interaction with someone, and that also the online stores had collapsed at this period because of the high rate of orders, and the couriers could not manage the distribution, and they were behind weeks in their orders. So we were like the only solution they had, and they were very appreciative of that. But regardless of that, when they return to a normal everyday life, they tend to go back to their own habits and finding the best price online, and keep the human element and the interaction for the pharmacist for something they need more urgently, and not something that they can program. So that's tampers little with the business model of pharmacists here in Greece. I don't know if that's the case in Canada
sure.
That's
I mean, we feel the pressures of e-commerce as well. But when you look at the pharmacy business itself, I mean, that's an opportunity. I see that as an opportunity. If they're coming into you guys and you own that relationship with them and they trust their pharmacist, and we know from Canadian data that the pharmacist is the most trusted healthcare professional beyond everyone, policemen, physicians, teachers, anyone. That's important. And that's why this evolution into a clinical model is very important, I think, for you as well. I mean, the pharmacy business, the dispensing will always be there in one form or another. The front store sales will be there. But where I think we have a very unique opportunity is to build on some of this other stuff. I mean, clinical service revenue went from, a small business to, a $250, $300 million business in Canada. Things like rapid testing, PCR, like we got to continue now. Patients are used to that now. So why give it away? Why give it back? I mean, those COVID-related services are going to drop down a little bit, I think, for sure. I mean, who knows? It looks like maybe we're going into another wave again, but it's set now the stage for us to build on that. And that's why I think things like pharmacogenomics, point-of-care testing, that stuff is there to stay. And I think it's going to be a huge business as well. I mean, if you look at something like pharmacogenomics, we have the ability now with a cheek swab to be able to predict how patients metabolize their medication. And in a space like mental health, that means a lot. We know the earlier you get patients, on the right therapy, the better they do long-term with something like depression, anxiety, right? And we have this available to us. And who's the best suited to do that? Because it's not the test. The test is going to become cheap soon. I mean, genetic testing is going down in cost all the time. It's who's going to offer that interpretation of the results, right? And that's where we're in that position to do it better than anyone else. We understand drug clearance, pharmacokinetics, pharmacodynamics. It's actually very, very simple. And in that randomized trial that I mentioned, this is exactly what we did. We took two groups. We took a control arm, which was, we called it standard of care. So these were patients that had depression or anxiety. They had some type of issue, either they were having a side effect, you know, their medication wasn't working or whatever, and we enrolled them. And then there was the treatment arm, which we had standard of care plus a genetic test. So they got a genetic test. We swabbed everyone, so no one knew what arm they were in, but we only released the results to the pharmacist that was doing the interventions in the intervention arm. And we followed these patients, and we followed them for 6 months. And what we found is and we were blind. Everyone was blinded. The only person that was unblinded was the research pharmacist. And what we found at 6 months, there was a huge difference. And we used scales, PHQ-9, GAD-7, to assess how these patients were doing, down the line, even scales that assess their quality of life, you know, their ability to interact in work and in school. And what we found is there was a dramatic difference, statistically significant, but also very clinically significant between those patients that had a genetic test versus those that didn't. So this paper now is kind of set the stage as a landmark paper where now we have reimbursement. So now, you know, something that started as a small project in community pharmacy has evolved to the point where third-party insurance companies are paying for genetic testing for their plan members in Canada. And that was based on that paper it was funded by an insurer as well. But we were able to show in the real world, when pharmacists are armed with this technology, they can make a big clinical difference. And I think we need to see more of that, and pharmacists globally showcasing kind of the innovative stuff that they're doing to be able to get more of this reimbursement into community pharmacies.
Could you tell us a little bit more about the interventions implemented by the pharmacists? Let's say dose adjustment, drug selection.
So there's actually two papers. The first paper we published a couple of years before that, and we looked exactly what you were talking about. So we wanted to see if pharmacists are armed with a genetic test, what type of interventions they made, or would they intervene, right? Because it's one thing to offer a test, it's another thing to intervene, right? So we found most commonly the pharmacist switched medication. Second most common intervention was they discontinued a drug. Sometimes they added a therapy, and and sometimes they increased monitoring. So there was some type of blood work or something that had to be done. But what we found in that first preliminary kind of paper was, on average, they were intervening 1.8 times per genetic test. So they were actually, it showed us two things. They were selecting the right patients, because they were selecting patients where there were potential drug-gene interactions. So they weren't just offering it to anyone, or we wouldn't have had those. We wouldn't have had those identified drug therapy problems, right? And anyone that's done a genetic test, it's not just about the test. You partner with a vendor that provides a report, and the interventions are based on evidence and guidance. So it says, if you're a slow metabolizer of a statin and you're on, Lipitor, the guidelines recommend you reduce the dose by 50%, or, change therapy or whatnot. So the recommendations are there. It's just up to pharmacists to use their clinical judgment to see, is this appropriate for the patient? Should we do it or whatnot?
Was this intervention on behalf of the pharmacist a suggestion, or was it an independent intervention? Let's say he had to coordinate with a doctor, or he would go ahead.
Yeah. So it depends. It depends what you're doing. And within our scope of practice, if you're changing the dose, you could do it yourself, right? So you could just change the dose. If you have to change the drug, then you have to involve the physician, right? So we documented that in that first paper. Physician acceptance rate was over 80%, which is quite high, actually. And it's not like in that 20%, the physicians were saying no. They didn't really know what we were doing. You kind of lose them. You didn't follow up. They weren't sure. So this was in the early days of pharmacogenomics as well. That's actually the paper that won first prize at FIP, because it was very early on, and we were starting to kind of do this work. And what lacked there, what question remained unanswered, was, were these interventions making any difference, right? And that became important, because some of the physicians would say to us, well, we would have done that eventually. We would have came up with that. Or, yeah, but timing is also important, right? So you could trial and error for like 2-3 years if you want, right? But if we could get them on the right drug faster, it can make a difference. And that's why we focused on mental health for a randomized trial, because mental health is something that you could more easily evaluate outcomes because there's the scales that you could use, like questionnaires that you could use in pharmacy, whereas some of the other therapeutic areas, GI health, for example, cardiovascular disease, it would have been more difficult for us to measure outcomes. Whereas, within 6 months in mental health, you should see a difference if you get them on the right therapy. And that's what we were able to do in the randomized trial. What was hard was logistically to do this in a community pharmacy because it's a very busy place. You got to consent patients. You have to make sure they remain blinded. It wasn't easy.
This is very interesting to me. Let me cut in, Konstantinos.
Absolutely.
Because I'm the hospital pharmacist of the group. So, and I also work in a mental health clinic. So I can totally get on board with what you're saying. It's not only easier to measure, but it's also critical to get the patient on the right treatment as fast as possible because it directly affects his or her prognosis, right? So you can't leave mental illnesses become chronic, then it's much, much harder, if even possible, to reverse.
And that's why we felt this paper was important. It was published in the Journal of Clinical and Translational Science, which is a medical journal, and they just told me it was one of their top 10 most downloaded papers. So it's interesting that a pharmacy publication in a medical journal would have that impact or that reach, right? But it just speaks to the fact that it really is real world kind of data. These are patients that are being seen by their physician, maybe even a psychiatrist. They're coming to their community pharmacist, and we're able to, improve their clinical outcomes. And I think the more data we have like that, I think down the line as a profession, we'll do much better.
You mentioned before that this kind of service is reimbursed by, let's say, private is that correct?
Yeah. So some private insurers, because based on the evidence that we provided. So I would say about 6 of the large insurance companies here in Canada now, will reimburse you if you want a genetic test. Green Shield, which is one of them, actually sent the communication out to the patients on mental health drugs that, hey, this service is available for free if you want to get it done. Go get it done.
So they're reimbursing the service, not let's say the outcome of the service, the intervention or the positive clinical outcome.
Oh, so they reimburse the pharmacy and the pharmacist to offer the service, right? And then it's up to you to kind of do but that's part of the fee is to do the clinical intervention, I guess, as well, right? Where we don't have coverage yet is from the biggest payer in Canada is still the government. We haven't seen the service covered yet, but it would be for them.
Good luck with
slow.
that.
Yeah, they move slow. Like it will, but as the price. So a genetic test is still about, if you're doing a good genetic test, one with at least 20 genes, multiple alleles, it's about $300, $350. So you cover a large range of therapeutic areas. That's going to come down, and the geneticists are saying it's going to be $50 or $60 soon. Like that, to run the panels is actually getting very cheap. The value will be, again, in the interpretation of the results. Someone has to sit and talk with the patient and make those clinical decisions, right?
I would, at this point of the discussion, I would like to be bold enough to ask for you to produce a crystal ball and make a prediction about the profession, about pharmacy, and what we are going to be practicing, let's say, in 10, 20 years from now. What are the new students going to get their hands into in the forthcoming years?
Well, I think the pandemic shot us forward in this crystal ball a little bit. And I think we would have been quite a ways away from some of the stuff that I think is going to happen. But I really believe the pandemic moved us forward at least 10 years, maybe even more, because of the value we provided. But here in Canada, we're already looking at our pharmacies. Like our pharmacy layout is set up for dispensing still, right? During the pandemic and even now, one of the biggest challenges we have is space. Where do we put these patients? This guy's waiting for a vaccine. This guy's waiting for a PCR test. This guy for a medication review. This guy for a genetic test. Like, where do we put them all? So really what I envision is our pharmacies to be becoming almost mini clinics where they're primary healthcare settings that are not like family doctors' offices, but we have these independent clinical rooms, and in my pharmacies, we could use 4 right now. And like I said, I even have a nurse that works there, right? So we're able to do all this stuff around blood work and everything else. But that's where I see us going. Is it going to happen quickly all over the world? Probably not. But I think it's extremely important that we document this journey as pharmacists, collect the data and show the value that it's providing, because that will help propel, the rest of the world forward. If you see some of our third world countries where vaccination rates are very, very low still, some of the African countries and whatnot. I was just in Qatar speaking at a conference in Dubai, and they have pharmacists that are available and accessible and want to do this stuff in their rural communities, small towns, and they haven't set up the infrastructure to do it. But you could really help these people in underserviced areas get vaccinated very, very quickly if you empower kind of the 4 million practicing pharmacists globally right now. And FIP has data on that, right? There's many, many pharmacists willing to do this type of work. It may be a slower movement in some countries than others, but many countries have already set the stage.
So can I ask the last question, please, if I may? What do you think about? Do you have at first? Let me ask. Do you have pharmacy specialties there? Like community pharmacy is a specialty, like compounding pharmacy is a specialty, like a cardiology, something like that. And if you don't have that regulated yet, do you think that that's the way forward?
Yeah, so good question. No, so I don't. I think we have specialty practice, right? So there are special certifications, like you could get a travel certification or respiratory certification, or certification in cardiovascular health. The reality is those don't affect your registration with the college. There's certain clinical standards that have to be maintained, irregardless of whether you work in hospital or in community. I remember I was in Europe at a committee meeting one time, and someone said, "Oh, I'm a clinical pharmacist," and I thought that was odd, because I'm like, isn't every pharmacist supposed to be a clinical pharmacist? But I do know in certain countries, community pharmacists are almost thought of as a different level in the hierarchy with a hospital pharmacist, and based on what they're able to do. But that's not the case here in Canada, and not so even in North America. I think the requirement to become a pharmacist now is that you have to be a clinician first, and that's how these students are trained. They actually don't have any skills in dispensing and all that. That stuff, they're almost surprised when they get into the community pharmacies now at how much of that still has to be done. The reality is we're trying to empower pharmacy technicians. There's different types of technicians now. There's a level called a regulated technician, who's able to check prescriptions, which frees up more time for the pharmacist to do some of this other clinical work. Sometimes I'm oversimplifying it, and I'm giving my experience and thinking that's the standard across Canada or even North America. It isn't. We have a spectrum of pharmacies still. Some pharmacies will do not much more than dispense, and then some that are very, very advanced practice. But I think the point I'm trying to make is if you stay on this end of the spectrum, you're a dinosaur. You're not going to survive in North America, because the revenue is going the other way. The value is going the other way. The value, they don't need you to dispense medications when robots can do it quicker, cheaper, more efficiently than you can, right? So really our skill set is in our knowledge and that relationship that we do own with the patient. I keep coming back to that. But that's the important part of this, is what you mean to your patient, what you mean to your local community, and the importance and the value in that service that you provide. And no one can take that from the community pharmacist. So if we're able to build on that as a core, we'll all be successful. But it's going to take some adapting by everyone, right?
So if I can spoil something for the next episodes of PharmaBabble, people know here in Greece that I ran a survey in the community pharmacy here in Greece because of the rapid testing that was commenced in September. And I was trying to find out what is the value for the patients and the pharmacists as well. One of the questions that I have in the survey was regarding if people want to receive more information about health problems and healthcare, from the pharmacist? And if so, what is the more appropriate way for them to receive this kind of information? In this question, I had the options of leaflets, of videos, of some wallpapers and stuff like that, and the conversation with the community pharmacy. So I will spoil the results for all of you right now, because up to 90% of the people that answered the question answered that they would like to get the information by discussing with the community pharmacy. And this was the only question in the whole survey that had that kind of acceptance and the same rates, which to me is mind-boggling in this era of internet and of this kind of communication which comes from everywhere, from the social media, from the TV, the radio, wherever you go, you get information. And still people, to this day, and from all age spectrums, answer the same thing. They would like to get the information from a human being that is correctly educated on that kind of matters, which comes to make more strong your point about the human interaction and what our strong suit is in that we deal with. I used to say that we use medication as a mean to serve people. Our main goal is to serve people, is to serve the community. The medication is merely a tool that we do that. It's not the end game. The end game is the patient, is the people.
Absolutely. And we have to build on that.
So I would like to thank everyone here. And I think what has come to a very nice conclusion is that in an era of continuous technology advancement, of automation, maybe the answer is to become more clinically humane, if I am getting the message right from all points of the horizon. So I would like to thank our guest.
Thanks for having me.
Thank you very much.
Pleasure to be here.
It has been an honor.
Hope to
Thank
see
you very much.
again.
Yeah, I'd be happy to connect again. I'll be in Greece this summer, so hopefully we can connect.
No, you're kindly requested to visit and discuss a little bit more.
Well, absolutely,
yes,
we'll get together
come to
anytime.
Our pharmacies and see what the culture here is from a real world perspective.
Yeah,
it will be intriguing.
Yeah, absolutely. No, thanks for having me. It's great to be able to share practices like this, and hopefully you guys continued success with your show, and hopefully you keep bringing on global guests. And that's, I think it's a great thing what you're doing.
Thank you.
We're trying. Thank you very much for your time and your knowledge.
Thanks, guys. Take care.
Να κλείσουμε στα ελληνικά.
Να κλείσουμε. Μπορείτε να κλείσετε εσείς, εγώ το άνοιξα.
Δεν ξέρω, ναι, όχι. Εγώ βλέπω αυτό που υποψιαζόμουν, ότι έχουμε όλοι τις ίδιες προκλήσεις. Η βασική διαφορά με το φαρμακείο του Καναδά και με την κατάσταση εκεί είναι ότι έχουν διαφορετικές ευκαιρίες. Εδώ εμείς στην Ελλάδα πρέπει να δημιουργήσουμε τις ευκαιρίες αυτές. Πρέπει να πείσουμε το Πανεπιστήμιο να αποδεχτεί τα δεδομένα του πραγματικού κόσμου που είναι άφθονα μέσα στα κοινοτικά φαρμακεία και έχουμε πολλή δουλειά σε αυτό.
Θα έλεγες όμως ότι μπορούμε να χρησιμοποιήσουμε το παράδειγμα του Καναδά σαν ένα είδος δικής μας κρυστάλλινης σφαίρας για να δούμε τι επιφυλάσσει ή θα μπορούσε να επιφυλάσσει για εμάς το μέλλον?
Εγώ αυτό θα έλεγα, γιατί όντας ο πιο έξω από τα πράγματα από τους τρεις, παρατηρώ ανατριχιαστικές ομοιότητες στις συμπτώσεις που οδήγησαν τον Καναδά και σε διάφορες επαρχίες του Καναδά, άλλες περισσότερο, άλλες λιγότερο, στο σημείο που είναι σήμερα.
Εγώ τη βασική διαφορά τη βλέπω στις δυνατότητες, στις ευκαιρίες. Αυτό δηλαδή στο πόσο εύκολη πρόσβαση είχαν, ας πούμε, στην κοινότητα των ακαδημαϊκών για να τους βοηθήσουν. Οι εταιρείες που θα θέλουν να αποζημιώσουν αυτή την. Όταν εμείς εδώ, για παράδειγμα, παλεύουμε να έρθουμε σε συμφωνία με τον ΕΟΠΗ για πολύ πιο αυτονόητα και πολύ πιο απλά πράγματα. Αυτό βλέπω εγώ ως βασική διαφορά.
Ας μην κρατάμε τα μας, λοιπόν.
Να μην κρατάμε τον κύριο.
Ίσως βάλουμε ένα section μετά οι τρεις μας για να κάνουμε ένα recap.
Να πούμε στο επεισόδιο στο οποίο θα παρουσιάσουμε τα αποτελέσματα της μελέτης αυτής.
Ωραία. Ευχαριστούμε και πάλι, λοιπόν. Καλή Κυριακή σε όλους. Να είστε καλά.
Ευχαριστούμε πάρα πολύ.